Dr. Nick Cates is a psychiatrist, professor, and author, and is a driving force behind the Canadian shared care movement. His groundbreaking work in shared care has been widely recognized, and he is the recipient of many awards and accolades. He is based in Hamilton, Ontario, where this model of care is flourishing. At our conference, Dr. Cates launched the 2011 position paper outlining a vision for the future of collaborative mental health care in Canada, and we were fortunate to have captured his presentation.
So where I'd like to start is just by going back a bit to 1997 and talking about why we came up with the first position paper that looked at how we could bring, in that instance, family physicians and psychiatrists more closely together, and lead into why we thought we needed to revise it a few years later. So we knew at that time, and I don't think much of this data has changed, prevalence was high, mental health and addiction problems often presented with comorbid problems, and primary care was playing a key role in the management. Since its publication, and I'm just going to highlight what I think are a few of the more seminal events that have happened over the last 14 or 15 years, I think the working group has played an important role, and I'll say a little bit more about that in just a moment. There have been two primary healthcare transition funds, one of which led to the creation of the Canadian Collaborative Mental Health Initiative, which I think played an enormously important role in both broadening the tent, bringing a whole range of providers, consumers, and community organizations together, but also laid a lot of the foundation in terms of the academic base for what's happened since then. 3 years ago, changes in the training guidelines for psychiatry residents. We're just in the process of implementing this. All psychiatry residents in Canada need to spend 2 months in collaborative practice. And I think it's critical that we get this right. I'll talk at the end about some of our priorities, but I think this absolutely has to be one. We've seen that collaborative mental health care is now, more and more it's being accepted as an integral part of practice. It's included in provincial and regional planning. We're seeing more and more Canadian models and evidence. And most important, I think it's expected by consumers, not just in mental health, but across the board. People want to see providers working together. And we've also seen benefits for the system as a whole. Collaboration improves access. It increases the capacity of both systems, both mental health and primary care, because more people are being seen in each system, and the two systems are part of one whole. It improves communication and coordination of care, and it uses resources more efficiently. But the other two areas have been a recognition that the consumer, the person, needs to be a part of the collaboration. And more recently, and I think particularly here, it's certainly one of the takeaway messages from this conference, is to include the families, not to forget the families, but also to include them in as many ways as possible in new collaborative partnerships. And I think the other thing that we've learned is that collaboration is only a means to an end. It's not an end. The point isn't to set up a collaborative relationship. The point is to get better outcomes through better collaboration. And what makes collaboration work? Personal relationships. I can remember going to Province House in PEI, and this is the sort of iconic non-picture of the Fathers of Federation. But there's a quote from George Brown, who was one of the Upper Canada representatives, who was commenting on some of the same kind of things, that it wasn't the meetings and the formal activities, but it was the informal contacts, the personal relationships that actually led to federation being achieved. And his quote was, he wasn't sure whether it was the eloquence of the speeches or the quality of champagne that led to the success of the enterprise. But most of their week was actually spent at balls and ice skating and barbecues and not actually sitting around a table talking. These are some of the other things. Just one interesting point about proximity. A study in Toronto looked at the distance between providers at which point collaboration starts to drop off. Any idea how far apart providers were when the degree of collaboration dropped off fairly significantly? 25? 60 feet. Once you were further than 60 feet away, the degree of collaboration started to drop and drop and drop. And that's about not even here to that pillar at the back. So, I think there's just a message there about, the advantages of co-location and physical proximity, openness to new ideas, shared goals, local solutions, and communication. Clear communication is essential to effective collaboration. It requires changes by providers. We can't just be doing the same things and saying now we're working collaboratively. The involvement and partnerships with consumers and family members, broader system changes, other system supports and effective ITs. These are just some of the supports that are required. We looked at a number of areas, but we felt the two critical areas. The first was regional health authorities and provinces who needed to look at links between mental health and primary care, fund innovative solutions to existing problems, prepare and support individuals who are working in collaboration in the field. And we also saw the benefits of local conferences and networks, not necessarily on such a scale as this, but exactly the same benefit that bring together providers, consumer, family members, and community partners to exchange ideas and get to know each other. Ways to share expertise and experiences. I think this is something we don't do very well in any part of the Canadian healthcare systems, but can we find ways, whether it be through CHEER that's coming up, or through the Shared Care website, or the conference, or listservs, or other ways, so that we can let each other know what's working. And if someone has a great idea in one part of the country, then why not look at how we can test it out across the rest of the country, rather than just coming to a conference once a year and hearing. And if we can do that, we'll start to get to what Tommy Douglas envisaged as the second stage of Medicare. Reorganizing the finances, etc., that was the easy part. To alter our delivery system to reduce costs and put an emphasis on prevention is the harder part, and that's, I think, where we are now. So what do we need to make it happen? I think there are three things in particular. We need the will. We need to want to make collaboration work. Not because someone's telling us, but because we believe this is integral to what we should be doing as providers, or what we want to see as consumers and family members. Then we need ideas. And we need new ideas, and we need to think differently, and we need to think creatively, because the old models aren't working, and they're not working that well. We need to go. We want to enhance the experience for the person receiving care and their family. And we want to enhance the experience of care for providers. We don't always think about this, but again, I think part of what we found in collaborative programs is it's fun. It can be enjoyable, and can collaboration help bring the joy back into primary care? But it's achieving three things: better health for populations, better experience of seeking, receiving, and you could add providing care, and doing it in a sustainable and cost-efficient way. But the key is that we're doing that all at the same time. Too often we develop a great program, but it's too expensive to replicate, and it's so good, but we don't have enough resources, so people have to wait a year to get in. How can we develop programs that actually achieve all those three things at the same time? And I think that's what needs to drive our thinking. But I think, again, the thing that drives and determines and is a characteristic of every high-performing health system is that at the center is the consumer and family, and that services are redesigned based. How can we reduce stigma? Stigma amongst healthcare providers, mental health care providers, that will make the experience for the person a more comfortable one, and hopefully a more productive one. Again, involving consumers and families as partners in their care, improving access and reducing wait times, and again, providing information. Dividing it up at the service level, early detection. Lots of opportunities for early detection, and that's the 18-month well baby visit. How can we identify children at the earliest possible age, but how then can we use collaboration to make sure that the 18-month well baby visit isn't an end, but it's a beginning? That we follow, we identify those kids who are at risk. When you look at the evidence of what happens to kids who are identifiable, not just at 18 months, but even before they're born, and what happens to them with no intervention by the time they get to be 10 and 12 and 18. And it has a horribly predictable course, but it's also a course that is changeable if the interventions are there. So can we begin to intervene in a different way? There's a nice quote by T.S. Eliot that says, "In my beginning is my end." Simple changes and improvements we can make, but there's so many ways we can use the phone for consultation, for backup, notifying each other after changes in treatment, pre and post discharge. Just pick up the phone and talk to each other. Email, it's a bit more than a phone, but again, all kinds of different ways of enhancing communication, because communication and contacts are absolutely the key to the success of collaborative relationships. And how can we do that with people that we're seeing? Can we start to use phone visits rather than face-to-face visits? Often a lot more convenient and a lot more efficient. We need to recognize that we work in complex systems and we have to tailor our interventions accordingly. How the kinds of systems that we're working with don't always respond to linear interventions. How can we begin to take that into consideration as we move forward? And how can we create cultures of improvement and innovation? How do we build cultures of improvement and innovation? We need, first and foremost, to be able to think differently. This is a quote at the Maudsley in London. "We have no money, therefore we must think." And remember, the Stone Age didn't end because we ran out of stones. We started to look at things differently. So it's not easy. It's a bit like trying to cross a bridge while it's still under construction. We're learning as we go, and as I say, sometimes not everything is going to work out, and sometimes it isn't quite as easy as we think it's going to be. We can look around and we can blame anybody we like. It's the government, it's the nurses, it's the doctors, it's whatever. We don't have enough money, we don't have this. And that could be the end of it. But that needs to be the start of it. That's the condition we're working with. How do we make the best of what we have? Do we just throw up our hands and say we can't do anything? I'm just going to go through the motions. Or do we say, let's look at little things that we can do? And things, we introduce an improvement with one person and we test it, and then the next day we sit down and say, did it work? What have we learned? And maybe we can try it with 2 people. And maybe it didn't work, so we'll try something else. But we're always looking at how we can move things forward. So I'd like to end with a challenge. This is a calendar, Saturday, June the 25th. What I'd like to ask you to do is go away from this conference and look at what you can do by Tuesday. What small improvement can you make based on anything you've heard here, based on looking at where you work or who you're working with? Just anything simple that you can test out, but by Tuesday. Don't put it off. And email me, because I'd really be interested in hearing how it went. And we'll put them up on the website as well, just around improvement stories. And the Meriden Group sort of started the conference with a quote by George Bernard Shaw about reasonable men and women, and how we needed to be unreasonable to move things forward. This is another nice quote by George Bernard Shaw, which I think really reflects where we are at the moment. Some look at things that are and ask why. I dream of things that never were and ask why not. And maybe finish based on that with a Yiddish proverb that says, if you never sleep, all your dreams will come true. Thank you.